sort of building up, enhancing, working on. Lots of work going on across the state. Folks are in just various different levels of getting MRSS up and running. And there's lots of different ways that folks are doing MRSS, from the initial crisis response all the way through the 6 to 8 weeks of services. So if you are here to talk about children and families, you are in the right place. I do want to, before we get too far into things, allow, first of all, invite folks to turn their cameras on if they're comfortable. It is not, I know the MCIS Learning Collaborative often has guest speakers. The MRSS Learning Collaborative is less about guest speakers and more about us discussing this new model and how to get it up and running and sort of the cultural shift from into this new sort of system, the children's system of care. So it's a little bit different model and a different setup for the MRSS Learning Collaborative than what we've been doing in the MCIS, because mobile crisis has been around since 2018, but the addition of stabilization services and the idea of how the idea of mobile crisis and also walking alongside families to make sure they get to the next place might not be a new concept, but it's new into rules. So thank you to those who turned their camera on, and if others want to join, I also don't expect you to have your cameras on the whole time, even if you can handle it for a little while. It's hard to be in meetings all day. So before we get started, though, does anyone want to introduce themselves? We've had a lot of new folks coming on board, and I just want to make sure people get an opportunity to meet each other, because it is a small community of providers working specifically with youth and families. Anyone want to introduce themselves to the group? First-time attendees.
I'm Bill Mankey. I'm the Crisis and Forensic Supervisor down in Frick County. 2 weeks.
Welcome, Bill. Yeah.
Thank you.
Nice to see you. Any other new folks? All right. If you are new and don't feel like sharing on video, I also just encourage you to put your information into the chat box so others know who you are. So I have a loose agenda today. My agenda was really just to sort of walk through the best practices for MRSS. Lauren and myself have been visiting virtually, having meetings with all of the CMHPs every quarter. And so we just started meeting with folks this month. We've met with about 10 different CMHPs, and it's obvious that lots of folks are in different varying sort of parts of getting MRSS up and running. So I thought it would be nice today just to sort of level set what is the vision, and then so that you guys can sort of see where are we headed, but where are we today and how do we get there? So that was my agenda item for today. But as always, I would love to see if any of you guys have any questions or anything that you would like to discuss. Since we have 30 some people here, I want to make sure you guys get your questions answered and are able to get support from each other if need be. Is there anyone that has an agenda item they would like to talk about today, or a situation or question that they need technical assistance from around? Jenny?
Yeah, I was going to say maybe this is already on your agenda, kind of within what you were going to talk about, but kind of the process for the referrals, kind of what the ideal, maybe the ideal of what the ideal referral process looks like, or which sources of referrals we're taking, and when we meet and connect with families, kind of what are we aiming for and what is acceptable.
Yeah, that is a lot of questions about sort of the workflow, right? And so as you guys are thinking about what you want your workflow to be, please feel free to jump in. I can talk a little bit about, like I said, we'll go over the best practices. So some of that will naturally come up. But thinking about workflow, what happens if your team, if the people going out to the crisis are not the same team that's going to keep the youth and family for those 6 to 8 weeks? What does that handoff look like? I've also had a couple of emails, or at least one email, where somebody was asking, if we're not the team that goes out for the initial crisis response, what do I do? Like, what's expected of me when I do connect with the family? What are the expectations within at that point? So lots of questions around that. Other questions or technical assistance areas that people would like to try to discuss today? I know someone put something in the chat, so I'm just opening it up. Oh, Carolyn, welcome, Carolyn. Oh, Dandy, welcome. Oh, lots of folks. Oh, Klatsip, Dragosh. Hopefully I said that. It's okay. Technical issues. Well, let's talk about let me pull up this and this is what I had planned today. Let me just pull up the best practice guidelines for you all, and we'll just go through them. I really hope and encourage you all to jump in. So I don't have to just be talking at folks today. I really am hoping that we can learn from each other. Like I said, I realize you guys are all in different sort of situations. So of standing up stabilization services, but I also wanted to just sort of level set. So here is a document that I've sent out several times. If you haven't gotten it, let me know. I can send it out again. This is a document from our friends over at the implementation Yukon, their implementation innovation services. I can't think of the name, but they're over at the University of Yukon, and they are the ones who are sort of promoting the MRSS model. This form that they created has the best practices for mobile response and stabilization services in green, and then also recognizing that, not everyone is going to wake up and tomorrow every single aspect of your program is going to be at a best practice, but there has to be some sort of a building up process, right? We have to be moving towards sort of the best practice. So this is just a way for you guys to track or think about, where are you at? Where do you want to be? And might be helpful as you're starting to think about what you want your stabilization services. So I'm not going to read all of these, but I do want to just recognize that MRSS really starts with the first phone call to whether it's 988 or the mobile crisis or your county crisis lines. That it is about, how do we encourage young people and or their caregivers, loved ones, parents? How do we start moving away from waiting until the windows are broken, waiting until the child is, has already hurt somebody? How do we sort of move forward and think about encouraging families, encouraging youth, but more so families and caregivers, to be able to pick up the phone and access your teams? And if we can also help shift that away from having the sort of historical definition of what a crisis is. So I know that a lot of that this is new, and a lot of you are in this process, but it really is about helping families be able to reach out and be able to access that response, that face-to-face response to their home. So the first piece there is that the crisis is defined by the parent, caregiver, young person. So historically, before we had stabilization services, we got a lot of feedback from families who said when they tried to access mobile crisis, sometimes they were told, we don't come out for 9-year-olds that don't go to bed. That's not a crisis. That's a parenting issue. And so we in Oregon, when we started developing the OERs, we wanted to sort of model after the states who are utilizing this MRSS model, which is if a parent is calling a public somebody, a stranger, if someone's picking up the phone because they're that worried about their young person and the behaviors are causing them stress as a parent, that is enough. It is enough. So again, as you see here, sort of thinking about we're encouraging families to call sooner than later. We would love for young people to call mobile crisis. A lot of times they end up calling the youth chat line, and that's enough for them. But we want to be able to have this sort of we go mentality. So I know one of the programs in Coos, I think they have their programs called Yes Program. And I love that because it's the youth empowerment model maybe is what it stands for, but it's based off if you call, we will go. The answer is yes, we will come. And part of the reason that's a model for young people is that a lot of times caregivers don't know what they need. They don't know how to assess the situation. They don't know what details would be helpful for you. We need somebody to go out and do that assessment and to assess in real time what's going on with the youth and the family and how they're sort of the dynamics in the home. So really shifting. So we're really trying to shift to encouraging the teams to go out for youth 20 and under. Anytime a caregiver would call, to go out rather than reassessing. And of course, we always want to de-escalate as much as we can over the phone, but thinking about the value of having a human being come. And often with children, and why this is different, a little bit different than with adults, is that with children, often your job ends up being de-escalating the parent as much as the child. So having the two-person team to go out, assess what's going on, be able to divide and conquer, but also this sort of threshold for what is a crisis. And we're really trying to encouraging us to start thinking from a more public health sort of social determinants of health, getting in there. And part of the assessment is to see what's going on and what this youth and family needs. Any thoughts about that shift? Where are you guys? I mean, and where are people with that sort of shift in their communities? How has it been with some of you have already shifted to, if we get a call, we're going out. I would love to hear from anyone how that's going.
This is Nova, Woodland County Mental Health. We go out regardless. The way our county does the MRSS services right now is that our crisis team responds to all crises, and then our MRSS team does the stabilization piece. So I guess for me, there's more frustrations around, I feel like we're working harder, not smarter in our county. I feel like that, like, if you are an open MRSS client, you have to have your crisis, like it feels like the old way. Like you have to have your crisis between business hours in order for your stabilization team to be able to respond, because they're not working after hours or weekends. And so then it's like, so, which is, you know, fine or whatever, but then that means the crisis team is responding. That means that like there's twice as many people working for one family, and then the crisis team ends up being like either I don't know, the rescue rangers that can always fix something, or like the bad news bears delivering bad news constantly. You know, it's like there's no like middle ground, and it just doesn't feel, for me, it doesn't feel client focused. I wish that I know, so I'm also a parent, and so if I feel like I would want the same kind of folks showing up all the time, and I wouldn't want to have to retell my story. I also know that when the shit's hitting the fan, and then the next day, I'm way calmer. And so I'm probably not going to share the same type of information with the folks I meet the next day, or the ones I see every so often. So yes, we do the response. Yes, our MRSS team responds if it's within their working hours. And also, I don't think we're doing it the right way in this county. I just don't.
Thanks, Nova. Yeah, the best practice is that obviously the best practice, and then is that when you go out, that the team that goes out to the initial crisis is then also part of the transition period, and if possible, that they may even get assigned certain cases to follow. Again, that's so that families don't have to retell their story. If you get out there and you de-escalate them during a crisis, you've already built a rapport. You can then jump in there the next day and do a deeper assessment. You get to see them at their worst, but then also they know you in case there's something that happens the next day or the next week. You already have built that rapport. That is one, that's the best, the model that's the closest to best practice. In Lane County, they have a team that just goes out for 20 and unders. So they go out for all of the 20 and under. It's the same team. They go out, they do the initial crisis response, and then they're going to be walking alongside the families that need more support. It's not necessarily a separate, it might be separate teams, but there has to be a warm handoff. If there has to be a handoff, there needs to be a warm handoff of some sort between the initial crisis response and the stabilization services. In Oregon, we had to pull those apart into the rules. So we have like MCIS for everyone and then stabilization services, when really MRSS as a model starts with the call to the hotline, call to your crisis line. And it's always thinking about responding to the youth and family, that even if the first responders are not the stabilization service providers, that you are trained to work with children, you're using child-specific developmentally appropriate tools, and that you're assessing what's going on with this family and do they need more. And the more is, do they need us to walk alongside them to get in here and continue to do a deeper assessment and help the youth and family figure out what is it that would be the best fit for them to help interrupt this process of escalation. Yeah, I can send this PDF out again for sure. Jenny?
Yeah, so kind of that was Nova, like what you were talking about is kind of similar, where MRSS team is the IIDHT team, and so they work full time, 80 hours or 40 hours a week. And so our MRT team is responding, and it's a different set of people. And so I was trying to figure out, because I got a couple referrals from the hospital that it seemed like they came into the hospital was saying, maybe you need to go to acute psych. The family or the kid is saying, I don't really want that. They offer MRSS as this get out of jail card. If you engage in this program, we'll feel like safer sending you home. But then it's over a weekend and MRT hasn't even been involved. And I get a referral on Monday morning and need to find a way to contact the family and do an assessment and connect with them. But there was no warm handoff between the hospital and me, or a team or MRT. And so then getting engaged with them when the crisis is over is really hard, because they're not seeing the need for it at that moment. And so I'm figuring out, like, if I can ask our MRT team to be the ones that go and do like a really simple assessment with them, or connect with them and at least just get paperwork signed and talk more about our program, so they don't leave the hospital without some more solid agreement to this process, at least.
So in our county, we go to the hospitals in the community. So if that was up here, we would have seen that kid and we would have made the referral to the MRSS team. So the hospital does not do direct referrals. They call us in regardless. And then as far as like, every single kid or every single person that's 20 and under, we just do a referral in our computer system. And then the stabilization team takes it from there. However, say that same person is struggling and it's the daytime and they're struggling in a way that somehow they've been sent to the hospital. The way it's set up now is our stabilization team isn't necessarily permitted to go into the hospital. Now it has to be the crisis team again. So there's that.
Yeah, I would encourage you guys to not get stuck in sort of to think about how to sort of create a workflow that is the least disruptive to the youth and family that makes the most sense. And Nova, I can sense frustration in your voice with just the state of sort of the disconnect between some of these pieces. Jenny, one of the things that I'm going to put, and I just pulled up the rules, is that it's really important. So I don't see your MCIS teams and your stabilization teams as being separate. I just want to be very clear about that from the state perspective, because again, you have to follow all of the MCIS rules for youth and families. You have to follow. And the last piece, I'm going to just show you guys the thinking. And I realize that we need to fix some of this in the rules to get it to better align with the national practices. But I wanted to just, and hold with me for a second here. Okay, it's not that section. So the initial mobile crisis response, this is the MR part for children, right? This is the MR, is that we're going to go out, but for youth and families, if they call and a parent wants us, we're going to go out no matter what. And then we sort of kicks into these rules, the OARs, right? We're going to go out. We're always going to make sure we're doing a suicide screening. If the suicide screening is positive, then we're going to make sure we do a more in-depth assessment and a crisis and safety plan. And you guys have sort of these different elements here that you could also do during their initial crisis. You just are thinking about it from a child and family perspective. Obviously, you're going to engage and figure out how to de-escalate the situation, the screening. You might have to do a SUD screening or a mental health assessment if needed in the moment to get a higher level of care. But also you may be doing a combination of these things, and some of these things are just optional depending on the situation. But what you are always doing for youth and families is this part down here. And I don't see where I wanted to, is that we're trying to also, the last thing you're doing is assessing and connecting them to services and follow-up services. That's where it goes into the next part, is the stabilization services for, whoops, that's not what I wanted to do, sorry. The last piece for youth and families when you're out there is saying, okay, well, what's going on? And would this family benefit from having a more in-depth, immediate access to additional services and supports? And so again, that's the first piece of this, is to think about every MCIS every time you guys are going out as an initial crisis, you should be assessing whether or not this youth would be a good fit for stabilization services. Jenny, the reason I was bringing up these rules was just to encourage you as your agency to make sure this piece here, G, that you have something that makes sense to you. This is a requirement from your agency, has to have some sort of a policy, a procedure, an MOU, something in place with the hospital that says what they are supposed to do and how they access stabilization services. Again, Nova's situation, she is going out, they already have an MOU and they do crisis response to their emergency rooms. But for those of you who don't, this is going to be really important, because we don't want the emergency room to have to call your county crisis line or call 988 or have you guys have to redo the initial crisis response. That was already done at the ED by the ED staff in some of your counties. So what does it look like for this to happen? And this is completely up to your agency, what you want that workflow to look like and what's going to work for you all.
Yeah, we have an MOU with the Bay Area Hospital, and they're honestly really great. The social workers that are there, but they had some turnover, and I'm obviously newer to managing this program, so I need to go back and refresh myself on the details of that. I'm wondering if it was new social workers just kind of doing that over the weekend and not having as much kind of connection. So thanks, Beth, for that reminder of kind of looking at the MOU.
The other piece of this too is to remember that the initial crisis response is up to 72 hours. So when you guys have 72 hours, at the end of that 72 hours is that kid's supposed to be connected to stabilization services by the end of that. So there's not like you go in and do yours and then there's like a referral process. It should be more connected, and that the 72 hours, the initial crisis response, we have that 72 hours so that you guys could bill for the follow-up, and that you guys, sometimes it takes you a while to track folks down or re-engage with them. But the time that 72 hours is over, you should have already have had whatever the next step is to get them attached to stabilization services. Jackie, do you want to jump in and ask about the screening tools and see what folks are using?
Sure. I just put it in the chat. I'm just curious if anyone is using. I'm of course looking for a brief screening.
Yeah.
As our teams are doing lots of assessments when they're going out, but specifically for youth, but also for adults, anyone's that, because as I'm looking, of course I'd want something vetted, and it's just not necessarily out there for a brief screening. So I'm like curious if people are finding it really useful and how it's going.
I really like the craft. That's just me personally, for youth, for the SUD screening. And I just like the language in it because I think it's really simple. And one of the questions, and the reason I like it as a child person, is it's like, have you been in a car with somebody who's been intoxicated in the last week or something? And I just always am like super impressed with that question, Jackie, because it takes it away from the kid having to say, yeah, I'm smoking weed, but being like, have you driven, are you partaking with people? Are you around dangerous? I mean, it's just a neat way of thinking about it. So the craft is one that I do. In IIBHT, we're using a brief screener, and it's only like 4 questions, and it's in Amanda's on here. Amanda, if you can put what the name of it is, it's one of the promise and practices, but it's by this drug and alcohol foundation. I don't know what the name is. Like, it's one that they're vetting. That's why we used it, but it's super brief, and you only have to do a more in depth if they do positive to any of the initial questions. So Amanda from OHSU, or anyone from OHSU, if you can remind us or put in there what that screener is that we use for IRBHT, that would be great. Anyone else though? What is other folks using? Anyone else using anything for that? I know our Bernardino was here a couple weeks ago from our drug and alcohol. He's the youth drug and alcohol person on our unit. He really likes the SBIRT. I don't know much about it, the SBIRT, and I don't know how short it is, but apparently he just got it. Yeah, the SBIRT he really likes, and he really promoted. And apparently they also just came up with an SBIRT that also has a suicide assessment or a suicide screening combined with it. So you'll have to do your own research, but it looks like Clackamas is looking into the SBIRT as well. Again. Any other thoughts, though, about from folks around the handoff from your initial mobile crisis team to sort of that next step, how that's going, tips or tricks, what's going well, what's hard about it? Jackie, yeah, I was like, I'm staring at you because you're on screen, and I know you hand off cases in the metro area. How do you guys do it?
Well, I hesitated because it's just the same thing. The providers are completely overrun with referrals. So,
yeah.
But like that's the narrative. So I just hesitated to say like, same. We're trying to refer. There's a long wait list, and we're just trying to maintain the household in the meantime with little bits here and there. But as you all can imagine, it's pretty intensive case servicing that they need. Like, connection and all that, and our teams are trying the best that they can to go on
Yeah.
calls and provide pretty intensive case management until we can hand families off.
To stabilization services. But really, you're doing stabilization, you're doing mini stabilization services in the week or two it takes to get them in, if it's even that short. Yeah. And I
Yeah,
think that that's part of it, is that the metro area specifically needs, we got our hands full. There's definitely a lot of youth who could use that 4 to 6 weeks of stabilization. So you're sort of doing mini and then handing them off when there's an opening. And I know that the CMHPs are working really hard on trying to figure out how to expand services. Because it is more case management, it's assessing, and you don't have to have a mental health diagnosis necessarily to get stabilization services. It's about walking alongside and helping the families stay out of the escalation cycle as much as you can to get them to the long-term services. But I hear you, the long-term services aren't always available. Amanda, I saw you just came in, and I actually had asked if you could do us a favor. Could you pull the name of the IIBHT SUD screener, the document we use for SUD screening?
Yes. Sorry, I had to drop
could
off
you
for 1
put-
second, but I'll put it in the chat.
Okay, thank you. All right. Any other thoughts about any of the? So let me pull back up and let's pull back up that best practice. If I didn't close out, well, okay, I closed out of the one I was using, but this is the same, just a different format. So this is just an easier, a smaller, a different format, but it goes into the, the best practices for the someone to call, right? So the process is, someone to contact, someone to respond. And then we've changed it for youth, or for adults, it's a place to go. For youth, it's a system to support, which is the stabilization services. So the someone to respond, obviously going in, trying to reduce, we went over the OARs, trying to figure out and de-escalate the situation, but then also assessing, right? After you de-escalate, assessing as much as you can if this family, it provides a warm handoff to the next services. And again, this is where the last piece of the mobile crisis team would say, how do we coordinate and get this family connected to stabilization services? And that's where the handoff from sometimes the initial crisis response to the stabilization services, if those services, and the idea, again, workforce challenges, the idea is that this isn't, you're not waiting for stabilization services. The idea is that it's immediate access to stabilization services, and the stabilization services are really someone to care coordinate and to work with the family and figure out what it is that this family needs to be successful. And then also a family support specialist that then can help sort of get in there and continue to work with the family while also connecting them to the next services. So that's the vision, and it's supposed to be short term, 6 to 8 weeks. But while you're in there, again, you're obviously updating and working on the crisis and safety plan, updating that while also assessing and figuring out what are the next, what is the family's needs, and how do you connect them. Has anyone have anything that they can share with us, or any experience about this going well, or having the handoff, or any youth that you have been serving in stabilization services? I've heard a couple really positive stories. I know, oops, I'm frozen. I know workforce is difficult, but curious if anyone has had a situation that they could walk us through. Any takers? All right. Well, if anyone thinks of an example, be happy to unmute and have you share that with us. We have been hearing a lot of successes, at least when I've been meeting with the counties and the CMHPs. They've been sharing how one of the things that just I've actually heard that there's been a huge increase. I think 3 of the 5 CMHPs we met with last week all said that there's been a sharp increase in youth and families and reaching out for mobile crisis in the last couple weeks. So I don't know if you guys are feeling that on your side or if you've seen an increase, but that was across the board, a lot more youth. I don't know if it's because school's getting close to being the end of the school year or because of the weather. I'm not sure what the variables are, but definitely have heard that. Any questions about the sort of model or the vision for MRSS or about the OARs that I can help? I did see one question up here by Blaine. Nurtured Heart is one approach that we are providing in Oregon. We're providing training in the Nurtured Heart approach. It's not necessarily a de-escalation strategy. It's more about how do you engage, right? The engaging with people, and how do we use language, how important it is to use language to try to engage, and how important that can be. So again, it's about assessing situations, but it's a lot of training around reframing and trying to look at what's going well and not just always looking at what's not going well. And it can be used by anyone who's trained in it. It's not dependent on diagnosis. It's not something, but we are offering that training to folks because there was a huge ask by child and family. The providers just across the board have said we need more training for folks on how to engage with youth and families, and how do we help new people who are new to the profession at least have some basic tangible skills to use in situations. So some of you all have gone. We'll have more trainings along the way. We also have collaborative problem solving. That training, there was 100 slots and it was only open for 5 days before it filled. So lots of folks excited about that. Again, that was open to all child and family providers, not just mobile crisis. And Amanda put some links in, but it looks like it's been updated, so we might be using an outdated form in our other program. So those are the trainings that we're offering. There also is the Training Academy. So again, we just finished up the online training academy, but there is a Training Academy in September. That's going to be in person in Bend. And there are some child-specific modules that if you're going to be working with youth and families, encourage you to take a look at those modules. All right. You guys are quiet today. Is there any other questions or anything anyone wants to brainstorm around? Got a great group of people here with lots of expertise. Misty?
Yes. Hi, Beth. I do have a couple questions.
Yeah.
I am at a computer without a camera, though.
Okay.
But I actually have a couple questions. I cover clinical services manager for Sherman, Hood River, and Wasco County. And we have yet to implement the MRSS program. I was training somebody as a mental health specialist, and then she gave notice. Yeah. So I have a couple questions revolving around, at a minimum, the MRSS needs to include a QMHP and a family support specialist, correct?
Correct.
So just wondering around thoughts about if we don't fill that QMHP position, just kicking it off with the QMHP, the one I have on the crisis team, and a family support specialist, just kind of starting with what we can provide, which is better than nothing.
I agree. I think that that's beautiful. I mean, I think you have to start with something. The role of the QMHP is really, the role is to be able to do a quick mental health assessment and a service plan. If you can do that during the first 72 hours, more power to you. And then the service plan, though, might be what do you have available that you could put on the service plan as interventions? Well, one of them is a family support specialist, if you have that. But if you have access to skills trainers and other people, it's not, it's more about assessing and continuing to de-escalate and continue to stabilize while identifying what the next steps are. Sometimes we find that the QMHPs can do a mental health assessment, but really it can be managed by a QMHA, and that 4 to 6 weeks of services is could be done by a QMHA. Maybe they're doing some skills training, maybe they're assessing, maybe they're helping doing some case management. It's the fact that they have a QMHP to do the initial assessment. And if you can do that during, however you want to do that is up to you all. And the service plan is only a 4 to 6 week or a 6 to 8 week service plan. So the service plans probably are going to be pretty simple too, which is, you're going to assess what the needs are. You're trying to figure out what is the family need and how do we get them connected. But yes, I think that you can do. We also are meeting with all of the CMHPs, and I believe I'm not sure when ours is with you, Misty. I feel like we might have just scheduled it. So we'll be meeting with you and talking about how to get you from where you are now up to the, in compliance.
Yeah, certainly. Thank you.
Yeah.
We have a significant staffing problem here. And it's been going on for years, and it's like we're no longer responding after hours to the hospitals.
Yes.
Among some other things. So it's pretty sparse out
Not
here.
good. Yeah.
My next question is, as I was bringing in the providers as medication management as a potential offer for the MRSS program, one of the concerns that they have is for the individuals that were not able to connect to services, needed appropriate services in that time frame, even so much so that I could see it extending like even 6 months. And our providers are very concerned about continuing to carry that individual and prescribe for them for families that maybe we can't find appropriate services for.
Yeah.
For those that are OHP, my agency is going to roll them straight into an intensive outpatient program if necessary, or just the outpatient. So I have that blessing from the agency to move that along relatively fast. But it's the kiddos that maybe have private insurance that our providers are very concerned about bringing on. And so they may not be willing to do that if it's not a requirement.
Yeah, well, I mean, they're going to have to make that decision, and I respect whatever their decision is that they make. I think with the private insurance kiddos, connecting them with the intensive care coordinator at the insurance and putting it back onto them as their responsibility to provide services for that youth. It might be all we can do in some situations, but I totally understand that. And it's not, the med management piece isn't required for MRSS, but it sure is nice when you have kids that you can then, assess and get started right away. But yes, we can't absolutely understand that there's going to be limits to that. And it also tells me that, we're going to have to do some more outreach with the commercial providers as well.
Yeah, that would be great.
Yeah, some outreach with them.
We really struggle in that area here in our counties.
Yeah, I just found out that they all have intensive, I don't know what they're called, but case managers. And I'm trying to figure out if there's a way that we can get a cheat sheet for all the CCO, all of the you know, the insurance companies and figure out how to have a cheat sheet for you all so you don't have to go searching every time you get a private insurance.
That would be helpful.
Yeah. I'm going to try my hardest.
Thank you. I appreciate that.
Yeah. Anyone else have any experience with so far with connecting kids in private insurance and about prescribers? I mean, my only other thing is just that you know, if they have a PCP, I know a lot of PCPs are not comfortable providing psychiatric medication to youth. There's a lot of PCPs that don't feel like they have that scope of knowledge. And I just encourage you guys to also just plug Opal K, which is the Oregon Psychiatric Access Line for children, K kids. But PCPs can sign up and get free guidance from a child and adolescent psychiatrist on medications. So that the whole hope for that program, right, is that PCPs, if they don't feel comfortable with certain medications, they can consult with an expert, and that expert can help make some recommendations to hopefully help relieve some of that, whatever it is, anxiety around it. All right. Anything else? We got about 4 minutes left. If none of you all have anything, I will say in the last couple minutes are what do you guys, how do you guys want to use our time? I know we started talking about this maybe a month or so ago. We talked about these meetings and about, do we have the right people here, and how do we start making sure that the MC, you know, the mobile crisis teams and the people who are following up with the services, how do we make sure that those teams are here so that we can have discussions about what we're seeing and more trends and things? But I'm just curious what topics might be helpful and for us to think about for next month. Especially those who are new coming in or just starting to build your services up. Any areas that you would like to be addressed next time?
Frankly, being new.
Oh, Bill, you're going in, you muted yourself in the middle of that.
Got you. Am I back?
Yep.
Yeah, okay. Well, being new, some of my favorite 2 words are cheat sheet. So if anybody has things like that, or we can put that on an agenda, or just even privately, I'd love to grab some of those.
Yes.
It's been
absolutely.
good to listen today.
Thanks for coming. Yeah, if anyone has anything, I think people are in the process of developing all of this stuff, so I'm not sure how many cheat sheets, but I'd be happy to help however I can.
Thank you.
And I will make sure to send out the documents I showed you all today and remind you that we do have a website, MRSS website at OHA, which has a link to a lot of helpful documents. And also, if you're still trying to wrap your head around what is this supposed to look like, we also you can also check out the Crisis Now website, which has a lot of recordings on various topics, but there are multiple ones that are specific to MRSS. I have some of them tagged on our website, but just going to the Crisis Now and looking for the ones that specifically have to do with the children's system could be helpful. All right, well, I'll stay on a couple extra minutes in case anyone has any questions to ask. Otherwise, I just appreciate you all coming today. And if you do have ideas of something that will be helpful